first of all, I think it's before we dive into the treatment and symptoms, I think it's important to first understand what addiction even is, or where that even potentially comes from. Addiction in itself actually comes from the Latin word to bound by or enslaved to. So it kind of gives a good insight into many of the symptoms and behaviors that will be seen with someone who does experience addiction. So this is, I know it's lengthy. I mean, I don't necessarily need to read it, but addiction is a primary chronic disease of brain reward, motivation, memory, and related circuitry. Dysfunction in these circuits lead to a characteristic biological, psychological, social, and spiritual manifestations. This is reflected in an individual pathologically pursuing reward and/or relief by substance use and other behaviors. So this is important. There's a lot in this definition, but I think it's important and I will break it down a little bit to see some of the components that lead to this. And again, this is the American Society of Addiction Medicine, which does identify addiction to be a disease, which is followed by the medical model of addiction. And secondly, addiction is characterized by the inability to consistently abstain, impairment in behavioral control, craving, diminished recognition of significant problems with one's behaviors and interpersonal relationships, and a dysfunctional emotional response. Like other chronic diseases, addiction often involves cycles of relapse and remission. Without treatment or engagement in recovery activities, addiction is progressive and can result in disability or premature death. So to break down that definition a little bit, there were a few things mentioned there that are important, and I think one of them is the chronic nature of the disease, which means that it's long-term and that there isn't necessarily any cure for it. I think that may be a myth. Now, it can be put in remission like other chronic diseases can, which may appear as if it's cured, which may present with no acute or symptoms of impairment, but yet the chronic diseases also allow for relapse, which was mentioned before, and actually is an expected part and almost routine nature for people that battle addiction. This was mentioned before also, but it is also a progressive disease, and this is important for someone who does proceed all the way through these steps from first use of experimentation to which can turn into social or recreational use, which can then go to abuse, and then dependence or addiction. Again, not everyone will go through this entire spectrum. Some will maintain. Now, again, with regard to opioid dependence, very rarely do people stop with experimentation, social, recreational. It almost always will run the gamut there and end with dependence. So the next, one of the primary symptoms here or behavior seen is continued use despite negative consequences. Now, this is something that is almost unique and characteristic to addiction, is that it doesn't necessarily follow a natural pattern of behavior or learning. So I put on touching the hot stove example. So we learn a lot through behaviors, and through that learning, we learn through unwanted outcomes or scenarios. I was speaking with an addictionologist, and she actually explained it to me. She said, this is the only human behavior that they've ever seen that doesn't necessarily follow this pattern. It's actually the opposite. There's actually sometimes as negative symptoms or outcomes occur, there's actually the craving can intensify. There isn't this automatic stop sign that comes up because of negative consequences, which obviously can lead to some very unwanted outcomes and overdose. And then craving, which is referred to as a compulsive urge to use a substance that can override rational decision making. And this is craving's I think a very important aspect of this, and sometimes doesn't get addressed enough, but it actually can be the first moment of a relapse or use, and that is because of the desire to use, which again overrides this rational decision of whether I should or shouldn't. So when people ask themselves, well, how could you do something like that? Or why would you put something like that into your body? Or what were you thinking? You hear this all the time. And the answer to that sometimes is this compulsivity to use overrides that. An example I often use is, I mean, even by show of hands, myself included, how many people have gone grocery shopping hungry? I mean, even though we may understand what the consequences of that may be, you may get home from the grocery store and look around and ask yourself, what did I actually buy? and how did I spend twice as much as I planned on? Does that mean that you are unable to shop? No, it just means that in a craving state, which hunger is, hunger actually is an initial stage of starvation, albeit an early one. Hunger is a craving state that alters your decision and behavior in the grocery store. It's a similar, yet much more powerful experience happens when someone's craving, especially high abusing drugs like opiates. And again, craving can be triggered by any number of objects, smells, activities, people, places, things. You name it. When the brain experiences high levels of dopamine, it attaches itself to almost all of the surroundings, which makes someone very vulnerable and susceptible to being triggered by things. And smell is one too. The olfactory sense is the highest correlated sense to memory. So many times people aren't even aware that, but even just a smell can trigger a thought, and that thought can trigger, it can start the potential for relapse process. I think, and again, just to touch on relapse too, which is obviously an ongoing component to addiction. Many people think relapse can start anywhere from 30 to 60, even I've heard even 90 days before someone actually relapses. Many times relapse is thought to be the actual use of the substance, which makes sense, but that thought process, that change can actually occur months before someone actually relapses, whether it be they start talking to Steve again, or they aren't going to 2 meetings a week anymore, they only going to 1. And there's this slow change can increase their exposure to triggers and have the craving increase. And again, addiction overall is influenced by multiple factors. This was addressed earlier in the first presentation, but genetics is a major factor to addiction. It's potentially 40 to 60% of someone's genetic predisposition is responsible for their vulnerability for addiction, which is a huge chunk of the problem. Then, of course, environment, that's both social and family. Mental health in a number of ways can relate to addiction, whether that's self-medication for previous trauma or anything like was mentioned before. Substance use, opiate use causes physical impairment, but it also causes emotional impairment as well. Onset of use, that's the age of onset. And so the earlier someone uses, the more likelihood that it will cause a problem later on in someone's life. They say if it's 13 or younger, there's a 3 to 4 times chance of developing substance dependence later on in life. And then drug of choice can influence things as well as the method of use, which was discussed before. That'd be snorting, injecting orally. So the signs and symptoms to look for, and this can obviously be very difficult to detect, especially with opiates. One, it's odorless. It is not necessarily going to be, there's most forms of it, unless it is smoked, obviously. But it can be taken in small amounts, which allows it to be concealed easily. And it doesn't take a long time to use. You can use it very, very quickly versus some other drugs which need to be taken over time. So one of the first symptoms that really speak to the addictive nature is the change in tolerance. So following patterns of repeated use, a higher dosage is required to achieve the same effect. This can lead to dangerous levels of use and or overdose. So not specifically for opiates, this can occur very, very quickly, potentially within a couple months. And can, again, lead to the overdose. So if someone's lethal dosage is here and they first start using here, their tolerance will continue to increase until they start to flirt with that lethal dosage, which leads to overdose. And as was mentioned before, if you don't know what you're taking, you can cross that threshold of lethal dosage pretty quickly. So withdrawal symptoms, these were mentioned before too as well, but this presents when the drug exits the body. For opioids, for heroin, this can happen within 8 to 12 hours after the last use. So for someone who is spending the majority of their day and time contemplating their next use, this can be an active running thought that just does not end because of this short time frame in which this withdrawal starts. Now, opiate withdrawal isn't necessarily dangerous, as that was mentioned before too, but I've had it referred to me in only one way and one way only, and that is, I'm dying. that is pretty much or I feel like I'm dying. It is almost commonly the only way it's expressed. And so someone who's experiencing that level of pain or discomfort, one is craving the drug intensely, and secondly, know that those symptoms will go away almost instantaneously if they use again. So those two factors alone are significant risk factors for relapse and continued use. So if someone is in opiate withdrawal, some symptoms you'll know are runny nose, nausea, vomiting, diarrhea, joint pain, or flu-like symptoms. The problem is if someone is using and they're trying to conceal their use, and any one of these symptoms could be stated because I have a cold, I'm tired, I don't feel well, and many people may accept that as what they're dealing with. Also notice an overall increase or decrease in energy and drowsiness. Again, they may just say they're tired. They'll nod out or appear to be in a sleep state. So you may actually see someone fall asleep in conversation or fall asleep watching TV or kind of just appear to be sleeping, with an overall decrease in motivation and drive. So you also have an inability to concentrate and focus. And again, this is due to the preoccupation of using the drug. Always thinking about the next use or when the next use is going to be or where they're going to use, transportation, money, needing a place to use, and on and on and on. I have a practice out in Waukesha County in the Aurora Medical Center in Summit, and so I see a lot of people in that region that need to get out to Milwaukee. So they have to find a ride, they have to find transportation, an excuse to leave, whether it be to their parents or their job. So it is a daily mission, so to speak, to be able to accomplish this. So there's social and behavioral changes, change in friends and peers, neglecting healthy lifestyle habits, isolating from non-using peers, and start to become more involved with using peers. And then there's a change in physical appearance as well as their emotional stability as well. So this again can look like tired, nodding out, constricted pupils. So the pupils actually become almost like pinpoints, and that'll even occur in dim light, which shouldn't be happening. And so that's one of the things to look for too is constricted pupils. Itching, slurred speech can appear disheveled, and again this is due to just an overall lack of motivation and interest for self-care and hygiene. And so appearance also changes within withdrawal states as well. So someone can appear agitated, anxious, again sick with flu-like symptoms, pale, or tired. So that brings us to the treatment aspect of this is what is it that we can do, which is a very complicated and sometimes head-scratching answer as far as what actually can we do as far as treatment goes. And that's simply because with addiction, and specifically with opiate use, there's a strong level of manipulation and secrecy and treatment resistance that has to be dealt with in order to get someone engaged in treatment, which we'll get into here in a little bit, but often requires a negative consequence to start a treatment episode, whether it be legally mandated, whether it be a health issue, whether it be a change in relationship, or something that initiates therapy. So these are just some statistics from the National Institute of Drug Abuse. So in 2012, 259 million prescriptions were written for opioids, which is enough to give every American adult their own pill bottle. So that was discussed earlier too with the overload of prescription medications. 4 in 5 new heroin users started out misusing painkillers. 94% of respondents to a survey of people treated for opioid addiction said they chose to use, it cuts off there, but it's heroin due to the cost of street medication for opiates. So you're looking at almost all of this progression towards heroin starts with prescription pain medication. And then only 1 in 10 people who are in need of AODA treatment receive therapy or treatment. So that leaves obviously a large chunk of people that are being untreated. This could be a number of reasons, like motivation. People could not have access financially or resourcefully for therapy, or just aren't motivated to get the help that they may need. So here are some principles for effective treatment. I'll just run through these quickly. No single treatment is appropriate for all individuals. Addresses multiple needs of the individual, not just the drug use. So there could be ongoing family issues, there could be unemployment, there can be financial issues, and a number of other stressors that may be involved that are also contributing to their ability to maintain or sustain sobriety. And that they remain in treatment for an adequate amount of time, not just necessarily a couple days or even a couple weeks. I believe one of the earlier presenters said roughly 3 years. So now not necessarily can someone stay in treatment for 3 years, but staying in treatment for an adequate enough time to allow some behaviorals to change and medications to begin working and to start to begin to develop a support system and network that is going to be present for the long run. Medications are an important element of treatment with counseling and support. Coexisting mental health disorders need to be addressed in an integrated way. Medical detoxification is only the first stage of therapy and is minimally effective for long-term change. So a lot of times what people will do is they'll enter a medical detox program, get through their withdrawal, maybe start Suboxone or start something, and then not follow up with an outpatient treatment, not follow up with their primary care physician, which makes them at a significant risk for relapse and then start the whole cycle all over again. And substance use during treatment needs to be monitored continuously, and this is, I think, goes to the point the woman in the back brought up about the Suboxone use, and these things aren't always taken the way we would like them to be taken. They're just not. People will, I've seen, you name it, I've seen it with people trying to, what they'll do to get urine into places, how they'll provide urinalysis tests. The lying and manipulation that goes with it can't be taken for granted. So even though someone may appear to be doing well, and the program is well run, their substance use during treatment needs to be monitored. And if you can, assess for HIV/AIDS or hepatitis B or C or other infectious diseases. And then just understand that recovery may require multiple episodes of treatment. I've seen people that have been 4, 5, 6 inpatient hospitalizations. Now, sometimes at different stages of someone's life, they may experience different motivations. So someone say, well, why would they need four treatments? Well, people's motivation can change, or reasons for seeking treatment can change, which can pretty significantly impact the outcome, hopefully in a positive way. So again, there's the medication-assisted treatments, and we've talked about these already, but buprenorphine, which is Suboxone mixed with naloxone, methadone, and then extended release injectable naltrexone or Vivitrol. Now, Vivitrol is a really sought after, but again, there's a price associated to it as well with insurance. It can be hard. I know with Aurora, it's offered through our opiate recovery program. But they do recommend that you have maintained sobriety for anywhere from 7 to 14 days, which can be a major barrier for some people because they can't get to that 7-day period before the initiation of naltrexone. So actually, in a treatment environment through a medical detoxification, or actually after a period of incarceration, after someone does get out, if that is sometimes the window of time that can be done for that. The good thing about the Vivitrol is it's monthly, once per month, so the compliance of it is great. The downside to Suboxone, which you can start, they say within 8 to 12 hours after, so you can actually start in withdrawal period, which is better for the person using it. But you have a compliance issue. You got to take it every day. You trust the person's taking it, not selling it. That they're not. Many times people use their Suboxone, to be honest, just to get rid of withdrawal symptoms. They're not taking it. They're not taking it for their opiate dependence as prescribed. They'll either sell it or stockpile it so they can use on the weekends and then feel safe during the week. These are the options that are out there for the treatment of opioid dependence and substance dependence in general, starting with residential treatment, which can be anywhere from a 30 to 60 to a 90-day stay at a residential facility, with potential for sober living facilities afterwards, and kind of long-term removal from a using environment with slow reintegration back into their social environment or family environment. Of course, that would be the highest level of care offered that would need for treatment. There's medical detoxification, inpatient treatment. Again, the primary purpose of that is to medically detox safely, and then provide a short 24-hour medically monitored treatment facility to begin someone's sobriety. But again, that would need to be followed up with either an intensive outpatient or outpatient setting, and hopefully with psychiatry or their general practitioner. Now, the downsides of some of those are what people say is, I can't do that. I've got a family, I've got a job, the barriers to that level of treatment are real for many people. Now sometimes the reality is that those things aren't going to be present anyway if they don't enter that level of treatment. But for some, they can't find that balance to be able to do that. So there is partial hospitalization, which is a pretty heavily intensive form of treatment as well, multiple days per week, multiple hours per day. But they do go home and then come back the next day, and that can last 6 to 8 weeks, even longer at times as well. Intensive outpatient therapy is a step below partial hospitalization. It's still several days per work, a couple hours per time, and again develops that higher level of care than outpatient therapy can provide. Outpatient therapy is beneficial if the person's use doesn't require higher level of care than that. I work in an outpatient clinic, and I'm often confronted with the difficulty of identifying if I can help someone really at an outpatient level, seeing them once every couple of weeks or not. Sometimes it's just not appropriate in the higher level of care, even if it might not, even if the motivation for them is lower or it's harder to get into, that really is the level of care that they may need. Or things can be supplemented with community support groups, whether it be AA, NA, HA, Celebrate Recovery, Smart Recovery. There's a number of community resources out there that can both support someone's therapy or for some people be what they primarily use.